Good morning. Welcome everybody to the IEHG Grand Rounds. You're all very welcome. Today, St. Luke's Kilkenny are kindly presenting, and I'm going to introduce Garry and Courtney, who's going to introduce the speakers, and from there. Garry is born in Omagh, County Tyrone, graduated from Trinity College, trained in general medicine and gastroenterology in Dublin and London, and appointed a consultant physician and gastroenterologist in St. Luke's Kilkenny. Garry, other appointments, co-lead in the National Acute Medicine Programme and clinical professor of medicine at the Royal College of Surgeons and tutor in our CPI. Importantly, Garry is a member of the working group that established the clinical directorates in 2008 and is the clinical director in St. Luke's Kilkenny. He's a great proponent of the group in general because in groups, the hospitals we know seem to work better than individuals. And that relationship with St. Luke's with the IEHG, I think it's been an important one. Garry's interests are acute medicine, viral hepatitis, interventional endoscopy, and inflammatory bowel disease. Garry, over to you.
Thanks very much, Tim, and thanks for the invitation for Luke's to present here and in connection with St. Vincent's. So we want to talk about Hep C today, and without further ado, I'm going to ask our excellent Ciaran McCloskey to present. Thanks.
Thanks, Prof. So good morning, everyone. My name is Ciaran McCloskey, and I'm a second-year SHO here at St. Luke's. And today I'm going to talk about hepatitis C treatments and really the global success story that it has been over the past decade since the advent of new therapies and how they've really revolutionized how we treat Hep C. So hepatitis C virus is a major global cause of liver morbidity and mortality associated with progression to liver cirrhosis and development over hepatocellular carcinoma. The estimated prevalence in Ireland is about 0.5%, or approximately 20,000 people. And of those who are exposed to the virus, about 3/4 will develop chronic infection. And of those, about 1 in 5 will go on to develop liver cirrhosis over a period of 20 to 40 years. So this graphic kind of illustrates nicely just the natural progression of the condition. So 3/4 getting chronic infection and going through stages of liver fibrosis onto cirrhosis, and then end-stage liver disease and hepatocellular carcinoma, which my colleague Caroline is going to talk about a little bit later on. I guess the important thing to note is there's a number of other risk factors which can kind of accelerate this process. So co-infection with HIV, hepatitis B, and a number of metabolic factors like increased BMI and alcohol consumption. So hepatitis C has been a notifiable disease since 2004, and since that period, they've kind of looked at potential risk factors for contracting the disease. So as you can see, the most significant risk factor is people who inject drugs, accounting for about 4 out of 5 cases, and then other causes, including sexual exposure and some legacy cases from infected blood products pre-screening in 91. So in Ireland, there's 8 hepatology units that are specialist centres for hepatitis C treatments. So there's 4 Dublin centres, and there's just a picture of our hepatology unit in St. Luke's here. So in terms of the overall burden of hepatitis C at present on the Irish hospital system, so last year there was over 2,000 admissions with Hep C as either a primary or secondary diagnosis. And 2/3 of those were actually in 3 centres, St. James's, the Maher and Vincents Hospital. And this graphic kind of illustrates kind of where we've come from. So in the 70s, there was a number of case reports that initially described this non-A, non-B chronic hepatitis. And then it would be a further decade until the RNA virus genome was actually sequenced in 1989. And then following that, in the 90s and 2000s, we kind of had interferon-based regimens, which were quite expensive, had relatively mediocre success rates in terms of actually clearing the virus, and were very poorly tolerated by patients due to a significant number of side effects. And really the revolution came when the first, I suppose, protease inhibitor, Boceprevir, was clinically approved in 2011, and then following on from that in 2014, we had a number of other direct-acting antivirals and the first all-oral regimens, and that really revolutionized kind of how we treat Hep C. So this graph here shows kind of the progression of sustained viral remission over time. And so sustained viral remission is kind of the gold standard for treatment. That's would be defined as an undetectable viral load taken on blood PCR about 12 weeks post completion of treatment. And as you can see with the interferon-based regimens, we historically had relatively mediocre SVO rates, and really it was the advent of the DAA therapies that really revolutionized treatment, with rates rising well above 95%, really changing how we view this condition. Just a little bit about the direct-acting antiviral therapies themselves. So like I said, they've been in use since the first clinical approval in 2011. They target non-structural proteins, kind of disrupting viral replication and the transcription translation processes. There's four broad classes. So protease inhibitors, non-structural protein 5A inhibitors, non-structural protein 5B polymerase inhibitors, and non-nucleoside polymerase inhibitors. And usually therapies are combination based, involving two or more classes, and they're targeted based on viral genotype and resistance factors. So moving on to our own data that we've conducted here at St. Luke's Hospital, we audited all patients treated between 2016 and 2022 at St. Luke's for Hep C with direct-acting antiviral therapies. There was 163 patients in total, including the study, and 2 patients were still completing active treatment at the time of audit. Demographic-wise, there was a 2-to-1 male to female ratio, and 62% were born in Ireland, with the remainder outside of Ireland. Regarding the protocol, so patients were seen initially, then at 2 weeks, 4 weeks, and then monthly thereafter. Decision to treat was always made after an NDTP discussion, and all patients received education from the pharmacy department on their treatment regarding interactions, what to do with missed doses, etc. And all patients received elastography at the time of presentation, which is a test which can measure liver stiffness, the degree of liver fibrosis, and likelihood of the presence of liver cirrhosis. In terms of genotypes treated, so in Hep C, there's 6 genotypes and 22 subclasses. And in our data, genotypes 1 and 3 accounted for only over 91% of our treated cases. And approximately a quarter of all patients had evidence of liver cirrhosis on elastography at the time of presentation. And this kind of just shows some of the treatments that we used. So like I mentioned earlier, the majority of these are combination-based regimens. Additionally, about a quarter of all patients received ribavirin, in addition to one of the above listed regimens. So 160 of our 161 patients achieved sustained viral remission, which is a remarkable SVO rate of 99.4%. There was only a single patient that did not attend for a follow-up viral PCR, but we're currently in the process of arranging for that patient to follow up with the GP for repeat bloods. There was 3 patients that had treatment-resistant strains, but achieved SVO on further treatment, and they're included in the data. And these findings are in line with published international data, highlighting the real transformation in treatment outcomes since the advent of direct-acting antiviral therapies, and really changing how we view this to now a potentially eradicatable disease. So the approximate cost of the treatment since 2016 was about 5.7 million euros. This would equate roughly down to about 35,000 euros per patient. Again, this is probably an overestimation. There is sensitive commercial pricing with a number of pharmaceutical companies where the full cost of the drug is paid and then reimbursed at a later date at a national level. But again, there has been a significant reduction in prices over the past number of years, particularly as more and more therapies have come on the market. And again, in some cases over 80%. So again, these are really becoming much more cost-effective therapies over time. So I suppose really the big message here is that effective therapies now make this disease potentially eradicatable, with SVUH rates approaching 100%, which is fantastic given how historically this condition has really been associated with a significant global cause of morbidity and mortality. Obviously, a lot of challenges remain. We're often dealing with very complex patient cohorts. Compliance with treatment can often be an issue, and these patients may not often have the easiest access to healthcare. So kind of trying to remove any further barriers and further reducing treatment costs are all things to look at. We also need to screen at-risk groups and kind of look at utilizing risk mitigation strategies like supervised injection centers. And then I suppose the data doesn't really show that patients who are treated for Hep C, it doesn't really confer any lasting immunity. So patients such as people who inject drugs are obviously still at high risk of developing reinfection. And then I suppose history would really tell us that development of an effective vaccine may be needed to complete, to kind of help achieve our goal in the long term in terms of complete eradication, which hopefully is something that more research will be going into in the coming years. But then just some kind of on a positive note, we can see here, like I said earlier, so Hep C has been a notifiable disease since 2004, and we can see here is the number of new cases notified each year. And although accounting for in 2012, there was a change in the definition. So they kind of no longer reported cases that were probably treated prior. But again, even accounting for that, we can still see a significant decline over the past decade. And also importantly, this is in the younger age cohort, and the median age is rising, which obviously these are the patients, I suppose, that the highest risk of developing the long-term complications of the disease. And as per the National Hepatitis C Treatment Program data, there's over 6,400 cases of Hep C have been treated in Ireland to date with direct-acting antiviral therapies. And then just kind of an end note on, I guess, a specific upcoming challenge in relation to the Ireland picture. So I suppose immigration is a very topical issue at the moment, and obviously we're all aware of the unfortunate situation going on in Ukraine. But obviously this significant amounts of immigration over the coming years will likely significantly lead to an increased need and burden on services here. So this is a graphic from 2008 in the Journal of Hepatology, which kind of showed estimated prevalences of Hep C across Europe. And as you can see, Ukraine there is the country with it's 4% in Eastern Europe. So again, their prevalence is much higher than our own of 0.5%. And I suppose even if you were to account for, say, 100,000 to 200,000 refugees coming here over the next couple of years, at a conservative estimate of prevalence of about 4%, this would likely lead to a 25 to 50% increase in the total number of cases in Ireland. So obviously, this would be a very significant increase on kind of the burden of services here. So really, I guess the take-home message really is that the advent of these therapies and new treatments over the past decade have really revolutionized how we deal with Hep C. It's really transformed it to a kind of a chronic condition that now is potentially eradicatable, and the long-term complications of the condition are really something that we should view as being completely preventable now with the success rates of therapies. Yeah, so thanks very much for listening, and welcome any questions.
Thanks, Ciaran. That was excellent, Garry, and thank you. Garry, do you want me to handle the questions, or do you want to? There's one coming in from Professor more on here that is of interest that might be worth asking.
No, go right ahead, Thomas.
So, Colin, you may want to expand on this if you wish. Could one regime be agreed to treatment which would decrease costs? So the question would be, I suppose, if you're doing combined therapy, would one standard regime be useful nationally and then the state could save money? I would imagine that might depend on the heterogeneity of the condition and infection, and I'd be interested, Ciaran and Garry, on that. If the condition is heterogeneous, then do you have to tailor the therapies specifically to the individual, or could you have a standard regime that would save money?
Yeah, it's a great question, Colin. So initially there was just really one drug company in the market and one treatment, and it was incredibly expensive. About $100,000 American dollars for a course, and now it's down, Ciaran said, to 35,000. But because of cashback really and sweetheart deals, we think approximately it's 14,000 euros per course. So the issues are, if it was chronic Hep C without cirrhosis, you can have one type of treatment and one course length. If it's chronic Hep C with cirrhosis, it's different. And then depending on, we like to use about 3 drugs, and sometimes ribavirin as well. Really, it's like if I can tell you, Colin, it's a bit like Helicobacter pylori. You do have to use a lot of drugs, and then the resistance factors are coming in. And we get superb help from the virus reference lab here, who can identify the unique resistance factors in those patients. We had 3 of them. And with retreatment with different drugs, it works. So we are gravitating more to certain types of drugs, but depends if it's NS A inhibitors or NS5B inhibitors, where there's a protease inhibitor required. So I think there'll be further competition and further reduction in prices here. But I don't think we can just hit a magic bullet for everything. Also, renal function also is a factor. And we've only really one pan-genotypic drug at the minute that will treat Hep C genotypes 1 to 6 at the moment. So depending on the disease burden, the renal function, whether they've cirrhosis, and also which genotype they have, it really is a bit more complex than that.
Thanks, Garry. I just interested, actually, just on that, follow up with that. I was noticed that men are more likely to have Hep C than women. And do we know biologically why that is, or is it the risk factor exposure? But then secondly, do you have a different approach to men therapeutically than women from your combination therapies or not?
Yeah, it's men. I think it's just the risk factor profile you mentioned, it's just drug addiction. And usually men are more into IVDA. Women, we have had the problem with the scandal with anti-D. Post-transfusion affected both groups. I think, I stand to be corrected, but I think pretty much everyone that was affected with anti-D in this country and post-transfusion Hep C are now cleared. And we're now down to dealing with the excluded groups in the community that Ciaran mentioned, the groups that are hard to contact. And this is the big challenge for us. So we had about 250 Hep C patients now in St. Luke's, obviously many more than that in the country, but we're actually down to our last sort of 50 patients to treat, and they're very difficult to get at. And that's why the National Hepatitis C Treatment Program will be moving to community treatments, searching out these patients in the community, doing the fiber scans, the liver stiffness measurement in the community. That is bringing the scanner and the nurse specialist to the patient in the community, and bringing the medication to the patient in the community rather than bringing the patient to the hospital for scans. So the male group of alcoholic, drug addicted, chronically infected Hep C are our next big challenge across the country.
Yeah,
Thanks very much, Garry. Just a comment, as an emergency physician, this has been a really good news story, particularly for people with needle stick injuries, because who we see relatively frequently, and especially in the sort of inner city high risk area where needles can be left around and in prisons. But, you know, when I started my career, the concern about getting hepatitis C was significant among people who got needle stick injuries, and HIV, course, and hepatitis B. But nowadays, you know, you can pretty much reassure people that if they get a needle stick injury, even if it was from a high risk source, that, you know, hepatitis C is almost completely treatable and can be eradicated if it's picked up early. And with HIV, the prophylaxis appears to be very effective. So you can be really reassuring to those patients. And so that's been a big change in practice in my career. So it's a good news story. So did we want to move on to the second?
Yes, so Ciaran's talk mentioned, you know, needle exchange programs, education to stop people getting infected. Then the DAs stop them getting chronic infection. But what do we do with the thousands of people in the country that already have cirrhosis? So that's why we need the assistance of occasionally and growing the National Liver Transplant Unit, and Caroline, Conlon and Ross McNicholas have kindly agreed to present from this aspect of the treatment. So thanks very much, Caroline.
Sorry, can you hear me now? I think my screen should hopefully be being shared now. So thanks to all the organizers for inviting us to speak. My name is Caroline Conlon. I'm one of the liver regs here in St. Vincent's Hospital. And as Ciaran has presented, the development of DAAs for treatment of Hep C has really been one of the great success stories of modern medicine. What I'm going to focus on in this part 2 is looking at our Hep C experience here in the liver transplant unit, focusing on liver transplantation, the use of DAAs in our transplant population, and also hepatocellular carcinoma. So first off, I'm just going to start with a short case. And so this is of a 60-year-old lady who was actually referred from Professor Courtney's team in Kilkenny to Vincents at the end of 2013. She has a background of hepatitis C cirrhosis, and she acquired hepatitis C from contaminated anti-D in the 1970s. She had significant portal hypertension with esophageal varices, splenomegaly, and thrombocytopenia. And as part of her follow-up for cirrhosis, she was undergoing HCC surveillance with ultrasounds. In 2013, a liver lesion concerning for hepatoma was detected. She proceeded to have multiphasic CT imaging and then was referred to the Vincents MDT for discussion. Following MDT, it was confirmed that she did have a solitary hepatoma in segment 3, and the decision was made to proceed with transplant assessment and local regional therapy. She was listed for transplant in February 2014. She had a TACE, which is a transarterial chemoembolization, at the beginning of April 2014, and she was lucky to be called for transplant at the end of April 2014. She had an uncomplicated post-transplant course and was discharged 2 weeks post-transplant. As all patients post-transplant, she had persistent hepatitis C following transplantation. However, she was offered treatment with the direct-acting antivirals in 2016 and achieved a sustained virological response, eradicating her virus. Fortunately, she had not developed graft cirrhosis prior to treatment. She's now 8 years following transplant, doing very well and with no disease recurrence. So just looking at our transplant experience here in Vincents, since the development of the program in 1993, we've done almost 1,300 liver transplants. 12% of the transplants have been performed for a primary indication or secondary indication of hepatitis C. And the main indications in the hepatitis C population would be liver failure or hepatocellular carcinoma. You can see that the median age is 52, again, a male predominance. Our 1-year survival in the Hep C cohort is 93%, and a 5-year survival of 74%. Over 40% of these patients were transplanted for concomitant hepatocellular carcinoma, and in this cohort, the recurrence rate is 21%. Again, the median age is also in the 50s and with a male predominance in the HCC cohort. Just to give you an idea of our survival data for our transplant cohort overall, the unit's 1-year survival is 92 to 94%, and our 5-year survival is about 77 to 87%. Previously looking at our recurrence rate of HCC overall, across all etiologies, it's approximately 15 to 17%, which is in keeping with international's results. So looking at liver transplants for Hep C, with the advent of DAA treatment, we've seen a reduction in referrals with Hep C related complications, including liver failure and HCC, and also we've seen a reduction in our transplants performed for Hep C. So prior to DAA treatment, we were doing approximately 8 to 12 transplants a year for Hep C. And you can see that since 2014 to 2016, when DAAs were being used, we've had a steady decline in transplants. We went from previously having treated patients with, as Ciaran has gone through, interferon, pegylated interferon, and ribavirin, which were poorly tolerated, associated with side effects, and treatments that we struggled to give to patients with cirrhosis and liver failure. However, now we're in an era of excellent treatments, which are well tolerated amongst patients, and therefore reducing the complications seen with hepatitis C. And so looking at then our treatment of hepatitis C in our transplant population, as we've said previously, with the previous treatments, the success rate was low and they were poorly tolerated. Following transplant, as patients had persistent hepatitis C, approximately 50% of patients developed graft cirrhosis at 5 years, and therefore were at risk of developing future complications, recurrent malignancies, and also recurrent risk of decompensation. However, since our introduction of DAAs, we've now treated 67 transplant patients. 90% of these 90% of these patients have been treated following transplant. And of those 90%, 45% had already developed graft cirrhosis. The success rates are much improved compared to prior treatments, and similar to the numbers that Ciaran quoted, our sustained virological response rate is 97% in this cohort. This is equivalent to 65 patients, and the 2 patients who did not achieve eradication actually passed away during treatment from non-treatment related causes. And so if they were to be excluded, our treatment success rate here in our transplant population is 100%. And just to discuss hepatocellular carcinoma, as it is a huge factor in our transplant patients for hepatitis C. It's a primary liver cancer. It develops from hepatocytes. Globally, it's the 5th most common malignancy worldwide, and it's the 2nd most common cause of cancer-related death. Approximately 85 to 95% of cases occur in patients with cirrhosis, and therefore that just shows the importance of HCC surveillance in our cirrhotic population. The most likely etiologies to develop HCC from a cirrhosis point of view are viral hepatitis, alcohol-related liver disease, and NASH cirrhosis or fatty liver. And the incidence of HCC in the cirrhotic population is approximately 1% per year. We can bring back our case here, just looking at the diagnosis of HCC. And so as our patient had in cirrhotic patients, 6 monthly ultrasounds for HCC surveillance, a liver lesion was identified, and she went ahead to have further imaging. Multiphasic CT or MRI imaging is the modality of, or are the modalities of choice, because we know that there are specific features seen with the flow of contrast through the liver lesions. We look for arterial hyperenhancement and also portal venous or washout on portal venous and delayed phases. And then there are radiological scoring systems that are used. Following the imaging, referral to the HCC MDT is the next step in the process. And here in Vincents, our MDT is made up of hepatology, hepatobiliary surgeons, radiology, pathology, and then a great team of HCC, ANP, and HCC specialist nurses. I haven't mentioned alpha-fetoprotein in this pathway, as we know it has a low sensitivity. As such, a normal result is not always helpful. However, markedly elevated results are associated with increased specificity, so it should always be sent and included in the referrals to the MDT. So once a diagnosis of HCC has been made, then we plan treatment. Treatment is dependent on three things. It's dependent on the tumor size and the tumor burden, the liver function of the patient. Are they cirrhotic, non-cirrhotic? Do they have significant portal hypertension, or are they decompensated? And then thirdly, their performance status. I'm not going to go into the diagram here, but this is the Barcelona Clinic liver cancer staging system, and it divides patients into different stages depending on those three factors, and then ultimately informing which treatment is best for individual patients. Our three curative options for HCC include liver transplant, resection, and ablation. From a transplant point of view, we offer this to patients who have small solitary tumors or multiple small tumors, all within certain size criteria. And I'm sure you've heard of the Milan criteria before. This is one that we would use. We know that small tumors and small tumor burden have low risk of extrahepatic spread, and patients with cirrhosis are at risk of getting further liver cancers. And as such, the best treatment is to take out their diseased liver and give them a new liver. With regards to resection and ablation, these are also curative treatments in patients with good liver function and small tumors, and have also excellent results. Our local regional therapies that we offer here are transarterial chemoembolization and also SIRT, which is selective internal radiation therapy, or radioembolization, and essentially we block off the tumors with chemo or radiation beads. These are non-curative treatments. They're sometimes considered palliative, and what they do is that they delay the progression of the disease. As you saw in our case, we use TACE sometimes as a bridge to transplant in patients who are being worked up for transplant or are on the active waiting list to delay progression of their disease. It can also be used to downstage tumors to allow patients to become within transplant criteria. And then for more advanced cancers, we have the options of our systemic therapies. Up until recently, the only systemic therapies that we had to offer patients were the oral tyrosine kinase inhibitors, either sorafenib or lenvatinib. And we've had some great success stories with these. However, they're few because they really only allow a short improvement in survival and are associated with significant side effects and sometimes reduced quality of life. And so recently, immunotherapy has come to the fore. And in the United States, actually, a combination of atezolizumab and bevacizumab has become the first-line treatment for patients with advanced hepatocellular carcinoma. We're lucky to have recently gotten compassionate access to the combination of atezo-bevo, which is a PD-L1 inhibitor and anti-VEGF. And we've started rolling this out with our patients here in Vincents. And we also have access to other immunotherapies through clinical trials at present. But ultimately, a lot of our patients require palliative care, and so they will form an important part of treatment of patients with HCC. Just looking quickly at our data about HCC secondary to hepatitis C. And so this is data kind of from about 2013. Over this time, we've had 124 patients referred to the unit with Hep C and HCC. 90% of them are cirrhotic. The majority of them are men. And you can see just their stage, their diagnostic stage at diagnosis. About 60% of them were early stage. However, almost 20% of patients were still advanced and terminal at the time of their diagnosis. And in a predominantly cirrhotic population, again, this just explains the importance of HCC surveillance in this population. The next box is a little bit complicated, but it just shows the first treatments that were offered to these patients. And it's 3 went on for transplant assessment immediately. However, you can see that the majority of the patients received TACE or chemoembolization, and just bearing in mind that some of these patients would have proceeded to transplant ultimately. And annually in Vincents, we do almost 200 HCC treatments, ranging from, this is data from 2019, and we had 12 transplants, 21 resections, 32 ablations, and 100 TACE procedures. At present, we do approximately 2 to 4 elective procedures per week. And how it happens is that the patients are admitted to interventional radiology in the morning. They have their procedure, so either their ablation, their TACE, or their CERT, and they're brought up to our liver ward following the procedure. All going well, most patients are discharged the following day. They then receive surveillance imaging at about 8 weeks' time, brought back to the MDT, and occasionally patients do require further treatment cycles. So just our take-home messages, chronic hepatitis C, which was only detected in the late 1980s with previous difficult treatments with poor success rates, is now curable and with short, well-tolerated treatments. With the advent of the direct-acting antivirals, we've seen a reduction in hepatitis C-related complications and, particularly here in Vincents, a reduction in hepatitis C-related liver failure and hepatocellular carcinoma. However, just bearing in mind that patients who have cirrhosis with Hep C who are treated and eradicate their virus, they still have cirrhosis and are at risk of developing liver cancer, and therefore it's important to make sure to continue ultrasound surveillance in this population due to the risk of developing HCC. And recent data has shown that overall there is a rising incidence of HCC despite good treatments for viral hepatitis. And this is due to the rising incidence of alcohol-related liver disease and also fatty liver in our communities. And so, and we saw there was Irish data published recently that showed that there was a 300% increase of admissions to hospitals for HCC-related disease, and that's through hype coding. So be aware of HCC, and if there's any concern, early referrals to specialist centres are recommended. So thank you very much. And I just wanted to say a quick thank you to our Chelsea Murphy, our transplant data manager, and also our HCC nurses and our Hep C nurses who helped collect some of our data for us today. And I'm happy to take any questions.
Thanks, Caroline. That's phenomenal. I'm not sure the juniors understand that certainly when I was training, curing something in medicine, it never happens. So it's a phenomenal story, isn't it, really? Well done. In my area of neurology, from an immune viewpoint, I think with multiple sclerosis, we've got very good, but we don't cure. So this is really pretty extraordinary story. I might pass this then over from here, I think, to Garry and the panel. And there's a few questions coming in. Tomas has a few of them. So the panel, we have Professor Ross McNicholas, Professor Aiden McCormick, I'm not sure if Aiden is on, Donal Carroll, Noreen Maher, Pauline Carroll, and Garry Courtney. And we might pass the questions over to them and get a discussion going. And please, if you have questions, bang it into the Q&A chat box.
Yeah, there's just one question again from Professor Colin O'Moore on why such a high rate of recurrence of HCC following transplant, and also get a recurrence of Hep C if previously treated.
Perhaps Ross could take that one.
Could take that. So we transplant people with hepatocellular carcinoma if we think they don't have extrahepatic spread. And the concept is if you have a single small tumor or several, multiple small tumors, the likelihood is the tumor will not have spread outside the liver. We scan outside, we do a CT chest for staging. We look at some other biological risk factors. For instance, an alpha-fetoprotein over 1,000 is a high indicator of vascular invasion and extrahepatic spread, but we can't fully eliminate the possibility of micrometastases, and that's why we see the recurrence. The simplest criteria that are used are the Milan criteria, which is a single tumor less than 5 centimeters or 3 tumors all less than 3 centimeters. And if you transplant within those criteria, you'll see about a 15 to 20% recurrence rate. There's a push to broaden those criteria for more numerous lesions or bigger lesions. The further we push out, the higher risk of recurrence. And the reason, again, for the recurrence is there's micrometastases that we can't see on the imaging. In terms of the hepatitis C, when I started in the liver unit, the patients that were referred up had decompensated liver failure. There was no ability to treat them with interferon or ribavirin because that would progress their liver failure. We didn't treat after transplants because the success rates were so poor. So interferon is associated with bone marrow suppression, amongst other problems, and these were very problematic in the post-transplant cohort. What we used to do was serial liver biopsies to stage the fibrosis progression. We'd expect 50% of people after transplant for hepatitis C to get graft cirrhosis at 5 years. And if they started to progress and develop liver damage, we treat, but with really poor success rates and poor tolerance. With the advent of the DAAs, this is just a totally different ballgame. It's a completely curative disease. And again, I just echo what everybody else is. It's absolutely amazing to see this from a virus that, you know, we didn't understand in the early 80s, non-A, non-B, to discovery in 89, to, you know, 99, to really 100% of people being cured nowadays. And these are really well tolerated outpatient treatments, 8 to 12 weeks, you know, occasionally out to 24. It's just a complete game changer. It's amazing to see.
Fantastic. Just another observation from the talk there. Caroline mentioned fatty liver or non-alcoholic steatosis and the risk of cirrhosis. Does that carry the same risk of HCC?
So the highest risk would be with viral hepatitis, hepatitis B and hepatitis C. The next highest risk would be hemochromatosis cirrhosis. Now, we rarely see hemochromatosis causing cirrhosis on its own, often as cofactors. The risk with NASH-related cirrhosis is probably less than 1% a year. The current guideline is that everybody who's cirrhotic should get surveillance ultrasounds twice a year. Some diseases that cause cirrhosis, for instance, autoimmune or primary biliary cirrhosis, the rates are really low and the cost effectiveness of screening it probably doesn't make sense, but we continue to screen all cirrhotics.
Very good. So it depends on the cause, essentially, the cirrhosis.
I mean, the risk depends on the cause, but in reality, if we know a patient has cirrhosis, we offer ultrasound surveillance, rightly or wrongly.
Yes, my other comment, I suppose I'm a bit like a broken record, but I think it's a great example again of how academic medicine can lead to new therapies. So the academic health science system is all about this, that if you learn the biology of the disease and whether that's the molecular aspect and the genomics of it, it can lead to new approaches from a reductionist approach, and then that can be brought back to the clinic. This is a lovely example, in many ways, of bench to bedside, and I suppose you could say bedside back to bench and indeed to community, because it's made a huge difference clearly to a community of patients who are now better and well and cured. So it's a lovely example of that. We've had a few other these similar presentations at this Grand Rounds, which is all about that, arguing that link between the major academic hospitals, level 4, level 3s, to the university and the community can lead to better care, better value, and indeed new innovations that could be of benefit to the state. I think we need to persuade the system to that effect because it hasn't been recognized, and it's not recognized that aspect of teaching, training, research, innovation that we've all assumed and presumed over the years does need to be supported. And it's a challenge dealing with the Department of Health and others that haven't quite got that message. They think that clinical care is just clinical care and that it's not built on the bedrock of all that academics. And this is a perfect example of that. Thank you.
Maybe I could just round off by saying there's been a big change in public health. There's amazing antivirals. The support from the National Liver Unit is amazing. We get our patients up and seen so quickly, great communication. But the other big change, I think, Ross, has been the evolution of imaging, which has really revolutionized. The amount of imaging that can be done for liver and other things now is fantastic. And I think the input of advanced radiology into the MDT and patient selection has again been a game changer.
I mean, I think that's absolutely right. I mean, lots of people had tumors 20, 30 years ago we weren't aware. I can remember struggling to get CT scans as a junior doctor, and now anybody who comes in with abdominal pain gets imaging. So 90% of hepatomas are diagnosed purely based on imaging. We don't need to biopsy. We don't need histology, except for 10% of the time. And Caroline alluded to a HYPE study we did looking at patients with liver disease being admitted. The 300% increase up to 2000, between 2006 and 2016. Part of that is there is an absolute increase in the prevalence of cirrhosis driven by alcohol, viral hepatitis, obesity and diabetes, but part of that is imaging. So we're finding these, whereas before we just didn't know.
Mm-hmm. And the other issue is we used to have interferon-based regimens. So here was giving drug addicts needles and making them inject themselves. It was a horrible side effects, quite expensive, didn't work really, lasted a year. And now we have tablets, can take an 8-week course. Some trials are now trying a 6-week course, very few side effects. And I have to say, a lot of potential interactions, but that's why we use our pharmacy colleagues, Donal's here, to see every patient that's going on treatment, to discuss with them their current treatments, using a computer database to look for potential interactions. And then almost no side effects, huge compliance because of very good nurse interactions with our CNSs. And then goodbye to the patients. And of course, the one patient that we lost moved to Cork, and you know how it is to get Cork patients to come back to Kilkenny. So the GP down there is trying to track him down. But I actually think, as Ross said, it's really 100%. But Ciaran did bring up the fact that we will have new Hep C patients coming, but we will have very, very good pathways to deal with them. So again, I echo Tim's response. I think this is a tremendous concept of bench to bedside and back from the bedside to the bench. It's a procedure. It's just rich in research potential as well, and of course very financially good for the drug companies.
Sorry, Garry, can I come in there for a second? Just on we've managed to treat a lot of the cohorts who actively engage with the hospitals. The people that we need to get to next are the people who aren't engaging with the hospitals, and that's to move the service out into the community a bit more than it is at the moment, and to get the engagement from whether it's the GPs, the community pharmacies. Now, the system was set up, it could have been 18 months ago or so, but I'm wondering, does it need to be accelerated? Does it need to be increased? Because when we get the influx of whether it's Ukrainians or whether it's just trying to deal with more chaotic patients, I'm not so sure that the links to the hospital are going to be as strong as they are for the patients we've had already. And if you look at the figures that we have, the figures that we're quoting, 95, 96, 97%, the 2 or 3% that we're losing, it's not that it's actively a treatment failure, it's just they're lost to the service, a lot of them. So we need to just work on those links into the community over the next few months, I think.
Yeah, Aiden McCormick, Aiden sends his apologies. He's actually been at a clinic since 8 a.m. But Aiden has been speaking with the group that's in the National Hepatitis C Treatment Program. And Conlon may come in here. That's correct, Donal. We have now to move to the community. We have, and it's probably a sancta care type concept. We have to send, it'll be our CNSs out to community. We have to find these patients. Patient finding is important. We have to scan them in the community, the elastography that Ross mentioned, and we have to treat them in the community. So community pharmacies, GPs, CNSs in the community, diagnosis in the community, that will be the lost group that's going to be a problem. And I see a few consultant posts coming through now from Dublin. I see them designated as inclusion medicine with specific remit for prisons, areas of deprivation, the homeless, and this is the group of patients that there will be a residue of Hep C in that we will have to go out, and this will be an expensive group to find and treat. Now, at the moment, St. Luke's provides treatment for Wexford, Tip, North South, Waterford, Carroll, and we will readily provide taxis. If we need the drugs go out, as you dispense them. It's cost effective to bring the patients in, provide taxis, look after them incredibly. That's why out of 165 patients, only one didn't turn up for their 3 months post-treatment SVR. So yeah, I think it's going to be a big issue. Dublin might be a bit easier because transport's easier, but for the rural community of Hep C, it's going to be really tricky.
Thanks very much. That's fantastic. And yes, we do have an inclusion health nurse here and inclusion health consultant as well. And so it is something in the Mater, we see a very high proportion of people who are homeless and intravenous drug users, people who inject drugs, and people from the prison. So I think that reaching out, as you say, has started, but it is very challenging because it's a very challenging cohort of people for compliance. So well done. Anybody else? Anybody else on the panel that wants to make a comment?
I think the next cohort of patients are going to be more difficult to find. I think we found the easy ones, and I think the map that Ciaran showed with the different prevalence rates per country is very important for the general practitioners, and identifying patients from higher risk countries and offering screening as they present to general practice is really important.
Very good point, Ross. Actually, we had a patient come into the ED the other day from Ukraine, and it's not clear to me yet where the primary care services are. I'm sure it's being discussed and organised, but something we need to be exploring.
I think it kind of captures a silo effect, doesn't it? It's difficult. That's a real problem. You know, academic health centre versus system, and how we reach out to the community and vice versa, which is going to be a cultural change and a body of work to be done. So a lot of the new developments of posts going in, for example, Sláinte care, they're all community-based, which is, I think, an issue. For example, I think in Area 9, which is between Maher and Beaumont, and there's 420 whole-time equivalent posts being appointed. A number of the meetings I've been pointing out, well, how's that going to work? If you're appointing an occupational therapist, a physiotherapist, a pharmacist, or a consultant, are they just going to work out the community and there's no communication with the hospital and vice versa? And then you're going to have with more silos, or are you going to be clever and you're going to have a system that they rotate into the hospital and vice versa, maybe for 2 months a year to maintain their CBD, but more importantly is to build up context. So you could imagine an inclusive service in hepatitis C would be appointments in the community, but into St. Luke's, Kilkenny and St. Vincent's Hospital, whatever ratio you need to do that with, but they rotate back and forth and they make the contacts, they attend the MDT by Zoom, and nowadays with virtual we should be able to do this. It does need a cultural change though, and we can't be doing silos, because otherwise we'd be just chasing our tail, and this group's going to be hard to get. We have a similar problem in my business, neurology. Colin Doherty's been tackling it a bit from an epilepsy viewpoint, and I look jealously what he's done. He's sort of done that over in James as well, and he's got that inclusive approach to it, because we recognize this. I'm on service, and you know, we've 2 or 3 patients coming in with seizures per day, often alcohol withdrawal. They're not being supported out there, and we don't manage them well. And this is across the system, so this is a good example, but it's a tough thing to get right, and it's going to need quite a bit of work and a cultural change to get there.
Well, yeah, if there are no further comments, thank you very much to everybody, particularly Professor Courtney for organising everybody, and fantastic presentations, fantastic story in health for hepatitis C, and another great IEHG Grand Rounds. So thanks to everyone.
Thank you all. Well done.